we have a 60-year-old woman with a history of type 2 diabetes, tobacco use, and severe arthritis of her knees. And she's been having new exertional chest pain for the past couple months. She undergoes a stress test, which was done with a pharmacologic myocardial perfusion imaging study, or MPI. And this comes back as normal and shows no significant perfusion defects. However, you wonder how reliable these negative results are given her multiple risk factors for CAD. So the clinical question that we'll be tackling today is, what can lead to a false negative result with MPI? Let's first go over how MPI works. So a radioactive tracer is injected first, which preferentially goes to myocardial tissue, and then images are taken before and after some form of stress. In general, exercise is preferred, but if your patient can't exercise like ours because of her knee pain, we can give medications to mimic exercise's effect on the heart. And for MPI, we typically give vasodilators that act on the adenosine receptor. This causes coronary vasodilation, which then increases myocardial blood flow. The most common way to obtain images in NPI is using something called SPECT, or single photon emission computed tomography. To understand what you're seeing when you look at MPI images, just remember that well-perfused areas will look bright and poorly perfused areas won't. So MPI images will look like this, where you'll see axial slices of the left ventricle. They look like an orange donut that, again, will look brighter the better perfused the myocardium is. So let's say we have a patient with a significant LAD blockage. While there may be no significant hypoperfusion during rest, once we give a vasodilator, non-obstructed arteries can dilate and significantly increase the blood flow to the areas that they supply. This, however, will then shunt blood flow away from the areas supplied by obstructed arteries. And then as a result, those poorly perfused areas of the heart after stress will lose its brightness. So let's just look at some examples. Here's a normal MPI where we have stress images in the top row and then rest images in the bottom. Even after being stressed, the myocardium is still uniformly bright throughout, and so there are no perfusion defects on this study. These images show that at stress, there is a perfusion defect in the LAD territory. Since this defect was not present at rest, we would call this a reversible defect, which is consistent with ischemia. And then finally, for this study, we see a perfusion defect that is there both at rest and after stress. So we would call this a fixed defect, which would be consistent with a prior infarct or scar. Overall, the sensitivity for SPECT MPI is pretty good at around 85%, though one area where it can underperform is in patients with multivessel CAD. There have been studies that show that SPECT can miss perfusion defects in 29% of patients with 3-vessel disease and 13% of patients with left main disease. And these false negative results are most likely due to what's called balanced ischemia. So let's go over what this means. It's important to understand that SPECT measures relative changes in perfusion. That's how we get the images on SPECT. So if you have someone with 3-vessel disease where you have global hypoperfusion, there's no one area that looks poorly perfused relative to the other areas. So this is true even after giving a vasodilator. All SPECT can see is that all territories of the heart are still receiving about the same amount of radioactive tracer, so it thinks that there are no poorly perfused areas, and this is what gives us a falsely normal study. One way to get around this issue is by getting an MPI with PET instead of SPECT. PET MPI can measure the absolute blood flow and so has better sensitivity. It is, however, more expensive and not as widely available, but the good news is, at least at this VA, all MPIs are done using PET. So that's all I have. Let's summarize. MPI uses radioactive tracers to visualize myocardial perfusion at rest and after some form of stress, whether that's exercise or a vasodilator. MPI with SPECT detects relative changes in perfusion. So this is why with SPECT, we can miss perfusion defects in those with severe multi-vessel disease due to balance ischemia. But we can overcome this issue by using PET for our MPI because we can get absolute blood flow measurements. This is why PET has higher sensitivity than SPECT. What questions do you all have?